Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi there, David Kaufman. I'm here with Eileen Ruhoy. Another episode of Unraveled. We really love doing these, just in case you guys haven't figured that out.
We have so much fun. I actually look forward to our recording days.
Me too. Anyhow, so the topic today is as a result of a comment or a message, in the Patreon message section. And again, please send in your messages, questions, answers, criticisms. It's really helpful. So this person wrote in basically correcting me on the definition of POTS, which was fine and really good. But I started to generate an answer and realized that I would probably write an answer that was 3 or 4 paragraphs long. And I thought, well, wait a minute, this is too important. Let's just do an episode on this, okay? So the reason I wanted to do the episode is there's POTS and there's POTS, okay? And I think the what I'll call confusion or disagreement or different way of looking at this between the person who wrote that and myself is, for me, recognizing this is less academic, et cetera, for me, the term POTS is like saying I bought a car, okay? It's just a label I use to say this person has got some huge major league problems and is a huge driver of their profound illness because there's something wrong with their hemodynamics. It is screwed up. Mm-hmm. And the label we use, or that I use, is POTS, because that's what everybody knows, okay? So yes, POTS has some specific definitions. So why don't we for a minute be scientific or academic and give the definitions, and you're going to be much better at this than me, okay?
Okay.
So, there's
Well, let's say it stands for
Postural orthostatic tachycardia syndrome.
Just to begin.
Do I remember that? Okay.
Right. Well, because it's important. Those words are important, right? Postural,
so postural
orthostatic,
means orthostatic,
right.
standing. Right?
Tachycardia.
Tachycardia means a fast heartbeat, generally defined as greater than 100 beats. All right, 100. Normal is called 60 to 100. Greater than 100 is defined as tachycardia. Mm-hmm. Postural orthostatic syndrome. Syndrome means we don't know what the hell's going on and why it's there. And that's actually the most important word in this thing. So thank you, because that's why I use POTS that way. Right. It is a syndrome, which means we don't know.
Exactly.
Okay.
Exactly.
And the first caution I want to emphasize, the first thing I want to say is, as we go through the definitions, my argument here is the definitions are constraining and restrictive and don't deal with the reality of patient care mm-hmm. and the way patients present and what is driving their illness. And if a physician only sticks to the restrictive definitions, they're just going to get the tip of the iceberg of pathology in these poor patients.
Right.
That's my big argument.
Right, and once again, it's going to be siloed, right? So I agree with what you're saying. It's just, and you've heard me say this a million times. I think everything presents like a POTS, and so people just say it's POTS. But I think that there are a lot of autonomic disorders. There's a lot of ways that the autonomic nervous system can go awry. It doesn't always fit criteria for a particular diagnosis, but I think that things look like POTS all the time, and I think also it specifically refers, of course, to the change of the heart rate, but it is one form of orthostatic intolerance. Obviously, if there is a change of blood pressure, then it's thought not to be POTS, and it's thought to be orthostatic hypotension. Exactly. But then there are, POTS has been talked about, written about, and diagnosed, I think, so much more in the last couple of years than ever before, but yet POTS has been around for a long time, right? So way back when, a lot of teenagers were being diagnosed with POTS. In fact, I think the average age of of a diagnosis of POTS was given to 14-year-olds. I remember reading that somewhere when I was working at Children's Hospital. And so it was a diagnosis often given to teenagers. It was thought to be related to generalized anxiety, stressors.
Of course.
It was thought to be one of these kinds of disorders, that there was just a fast heart rate because they were having an anxiety attack. And I don't even know.
More common in girls. 14
more common
is
in girls. It was like a 4 to 1.
Therefore, it was more likely to be the anxiety.
Exactly.
And social pressure and all that crap.
Exactly.
Yeah.
And then the range of ages were, I think, like between 12 and 50 even. So, but it was thought to be related to anxiety and stressors in the world, and people weren't handling their social studies class well in high school. Or do they still teach social studies?
I think. Maybe not in certain states.
I'm certainly dating myself.
Sections of the country, they've wiped out social studies. You're not allowed to discuss
That's right.
social studies or civics for that matter.
Oh, my God. Okay.
Family values. You can do family values. Sorry. Go ahead.
Okay.
Rewind.
I should have just asked
Maybe
about
we should
geometry.
ask Blake to delete that. All right, go ahead.
But over the years, I think it's gotten a lot more attention. I think largely because of long COVID again. Because there was this upsurge of POTS diagnoses that were seen in these patients who had COVID.
But still missed all the time. I had a patient come in last week. It took her 3 years for somebody to say, I think you have POTS. 3 years.
Wow.
I mean,
I'm shocked to hear that, because I feel like everyone's just told that they have POTS.
It's just unbelievable.
If they say that their heart rate
and then they
goes
say,
up.
oh, you have POTS, just drink more fluid. That's it. That was the plan of care for this person who could not walk or stand up. That upsets me a lot, because despite the fact that I agree with you, it's just sort of this umbrella term. It doesn't really have great significance. There's still important, specifics to learn about it, and then treatment to do about it. And then, so because of the upsurge of this diagnosis, there's been a lot of, more research, more descriptive terms, and there are now 3 subtypes, as you know, and there's a tremendous amount of overlap. So I hate to even refer to them as like different subtypes, but there's the neuropathic, there's the hyperadrenergic, and there's the hypovolemic. Right. And so the neuropathic is thought to be mediated by small fiber neuropathy, and it changes sort of what we refer to as peripheral venous capacitance, and it just means that there's a vasomotor dysregulation that goes along with it, so the vessels don't constrict or dilate appropriately to a challenge of position, and so that therefore a change of volume, and so the vessels don't accommodate as easily, and that's thought to be the neuropathic form. So there's a small fiber neuropathy that you can see on a skin biopsy. There's the hypovolemic, which is thought to be related to the renin-angiotensin-aldosterone system, which is somewhat fairly new, I think, and that's sort of interesting to me that someone even bothered to consider like what really will change volume status. And now we're talking about the renin-angiotensin-aldosterone system, which is interesting, of course, because then you think about COVID and angiotensin receptors, and then you think about even the cell trend panel, frankly, which has a lot of those autoantibodies against those particular receptors, which I know the cell trend panel has been controversial even amongst our own peers. But I think that the more you learn about these specifics with regards to dysautonomia, the more these things are a whole lot less controversial, or at least make a little bit more sense, that you could potentially use as a treatment option for patients. And then, of course, there's the hyperadrenergic, which is just from catecholamine excess, norepinephrine specifically, and that creates like a sympathetic surge kind of. So very helpful to give those 3.
Right,
categories.
And that's sort of how it's classified, but there's a lot of overlap.
And my argument, and this is why I call it POTS, is that I would argue I've never had a patient with POTS, my POTS,
who fit into one of those subtypes.
They fit into all 3 subtypes.
Exactly. That's what I meant. There's a tremendous amount of overlap.
The minute, as a physician, you say, oh, you have autonomic POTS,
right, you're
going to miss the fact that patient has a volume issue, and the patient actually is having a fight or flight every time they stand up, which is hyperadrenergic. And that's why I try to use this broad term.
You're absolutely right about that, though.
And the impact on that approach, treatment-wise, is huge. Mm-hmm. Okay, it doesn't mean I make every person better when I treat their POTS, but it means I'm going to miss less things, okay? And I'm going to be more open and ready to try different approaches and interventions. The other piece I want to quickly add in, because I don't want to lose it, is, these names have operational definitions. Mm-hmm. So POTS is your heart rate has to spike greater than 30 beats from baseline. I think it's greater than 30 beats for baseline over 10 minutes.
Right.
So that means that if the patient is spiking 20 beats over baseline and is starting to faint, you don't have POTS, go home, you're just a neurotic
Right, because you don't
mess.
meet the criteria.
And
That drives me nuts.
It gets me insane.
I know.
So for me, POTS is something's wrong when you change your position and it causes symptoms. To me, that's a more functional, operational, useful definition.
I mean, that's all a patient has to tell me. Like,
Yes.
honestly, like, I mean, as you know, I do autonomic testing, but I don't, and I do it just to get objective measurements because I know that sometimes it can help, the patient when they go see other doctors, and it can obviously clarify a diagnosis. But like, all you have to tell me is that when you stand up, you're symptomatic. And what are the symptoms? So dizziness, feeling like you're going to faint, nausea, sometimes chronic pain, sometimes cognitive slowing.
Yeah, and let's spend a minute on that, okay? So unfortunately, most physicians, and in fact most patients, will say or think, maybe I should say think, that the symptoms to consider for POTS, for orthostatic intolerance, is do you get dizzy or feel faint or lightheaded? But that's like saying if you see the tip of the iceberg, there's nothing underwater.
Right.
It causes brain fog. It causes gastrointestinal dysfunction. Yeah. It causes pain. It causes muscle weakness. It's probably a major driver of post-exertional malaise and the mitochondrial dysfunction that's associated with it. So you need to, as physician and patient, ask about how you feel when you change position and this is happening. And I have seen so many patients who say, well, I don't feel dizzy, so it's not POTS. And I say, well, yeah, but you can't add 2 and 2 together, so you got POTS, Sorry.
No, but you're right. There are so many symptoms that come from that change of basically the ability of volume in general, right? Because it'll pool. What's interesting is, studies have shown that these hypovolemic, we use that term, these patients on testing-wise don't really have low volume of blood. They actually have normal volume of blood. It's how the blood is handled. So there's this idea. So certainly dehydration can cause these symptoms, and dehydration is thought to be a low blood volume situation. But hypovolemic POTS is not technically low blood volume. In fact, studies have shown that these patients generally have normal volume. It's just how it's handled.
Right. Which again shows why if we stick to the definitions, we're going to miss so much.
That's
so
right.
When you say how it's handled, one of the things that means is that in EDS patients, which are a huge proportion of our patients, interesting
joint hypermobility is associated with. So this is the literature's all over the place, but I read anywhere between 30 to 60% of POTS, of patients who are given a diagnosis of POTS, have joint hypermobility.
Right. A profoundly important thing.
Yes,
and one of the problems is that the veins are more distensible. They're more stretchy. So you might have a great volume, but if it's all in your toes, it's useless to you. Seriously. So it's a huge issue, and again, that doesn't fit into those definitions.
No, it doesn't.
So if you stick to the textbook definitions, you're just not going to do your job.
No, you're not going to do your job, and it's also not predominantly autoimmune, which is another thing I regularly hear people say. I think only 20% of patients have an autoimmune etiology of it, and it's the ganglionic acetylcholine receptor antibody. But it's not mainly autoimmune. In fact, it's often other things, and even those subtypes, none of them really specifically are about an autoimmune component. But it is important to check for that antibody, of course, regardless.
The other thing, again, the reason I struggle with the definitions or with not being imprisoned by the definitions.
Right. I think that's the better way of
is that I've seen over and over patients start in one definition and end up in another. So I've had patients who have a volume and autonomic component who end up hyperadrenergic. And I can see it in my chart, whereas they had POTS with a drop in their blood pressure on the first year I knew them. And then in year 3, suddenly they're standing up and they're hyperadrenergic. Their blood pressure is 160 over 112, and their heart rate is 130.
Yeah.
And they just flipped.
It can vary from day to day, right?
Yeah.
It even depends upon, any kind of stressors to their body, whether they just had a concussion, whether they had a viral illness, whether they're going through hormonal changes.
Or just some adaptation. We are very much living, constantly changing organisms. And we are here. We've survived evolution and whatever because we are adaptive. Our systems adapt. And so in some ways, it's not surprising for the orthostatic hypotensive patient with POTS to turn into a hyperadrenergic because the body wants that extra blood pressure and perfusion to go, so it flips to hyperadrenergic. Not productive. It's not a great flip, but you can
That's a
understand
really
why
good
it would
point.
happen.
This just sort of might be like a continuum, these different three subtypes of the
Right.
body's homeostatic response, and that whenever that patient might be tested along that timeline, they might fit a particular subtype definition, and then that the doctor will think, well, this is what you have, and now you'll have this all the time, as opposed to sort of always revisiting it and revisiting the symptoms, and importantly, revisiting, what treatment options have been tried and what you've responded to, what you haven't responded to, because we well know that, we try all these treatments and sometimes they work and sometimes they don't. Sometimes they work for a little while and then they lose their efficacy. Sometimes they don't work at all. And sometimes we revisit them like a few months later and then all of a sudden they're working. So I agree with you. We cannot be imprisoned by these definitions. And we say this every single time. We have to listen to the patient.
Yeah.
And in fact, I start every appointment with tell me how your symptoms are. And I know that they think that they're just repeating their symptoms to me, but I want to know how they are today because we last spoke 3 months ago. Kind of thing.
And if there's a change, why?
Right.
Can you identify a cause or causes that might have led to a change? Was it the weather? Was it the temperature? Was it a medication you tried? Was it a fight you had with your partner or something like that?
Right, exactly. Yeah. And so it's important not to be shackled by these, very specific definitions of anything. And in fact, the autonomic nervous system in general is complicated and complex.
Right.
And there are textbooks written on autonomic function because it does control so much of what our body does. And it's got tendrils everywhere. And so to sort of say that, one thing went wrong and it's the only thing that's going to go wrong, and it's contained in this little.
Well, that brings us back to our theme that we're on all the time of it's all interrelated, it's all interactional, it's all bidirectional, multidirectional, thus the concept of septed. And autonomic is everything. I mean, it's like saying, are you alive or dead?
Right. Right.
It's all interacting. So, and that's key to understanding
the
this.
sympathetic versus parasympathetic. I mean, it's sort of what keeps us alive, right, when you think about it. And so it's important not to just sort of focus in on one particular diagnosis and then just sort of stick to that. It's important to sort of continue to revisit the autonomic nervous system. It's also important, by the way, not to just sort of label something as POTS and just be on about your business, because you don't want to miss something that's more serious that might just sort of be starting. It looks like it's just a sort of simple POTS kind of label, because you could miss something very significant that's progressive and potentially very
well. And so to that point, do you have POTS because you have long Lyme, chronic Lyme disease? Do you have POTS because you have wildly uncontrolled mast cell activation syndrome or reactivated EBV? All these infectious illnesses cause an inflammatory response, mast cell degranulation, all these different things which can end up aggravating, causing, accelerating POTS.
Right.
All right? Now, when I say POTS, I'm saying it may decrease your volume. It may cause hyperadrenergic response. It's not just one thing, but, it's part of a whole picture.
For sure. And it's also might be part of a different picture as well, right? So for example, I have a lot of Sjogren's patients who have dysautonomia and have some form of POTS, or something deeper than that. I have patients with systemic lupus erythematosus, patients with rheumatoid arthritis. A lot of connective tissue disorders, and so not just EDS, but a lot of autoimmune connective tissue disorders have dysautonomia that go along with it. There are vasculopathies, there's neuropathies. My point is that very often something that is thought to be POTS is part of a bigger picture that can easily be missed if you just
symptom, but it's not the cause.
And it is a presenting symptom often, right? Because the heart is so sensitive to things, as it should be, right? It's it's an important organ. And so it will very much respond to any kind of alteration of the internal milieu. And how will it respond? It'll change its heart rate first and foremost, right? So it'll go up. And the tachycardia is what people will say. I feel palpitations, so like my chest is racing. And then they say, oh, you have POTS. You have anxiety and you have POTS. Right.
Go get some physical therapy.
Drink some water. No, it's so true.
So, I do think that regardless of whether there's other underlying causes, patients with POTS have a perfusion disorder.
Yes.
And that is not the, although often I think it is the major driver of their illness, meaning their symptoms. And I just totally believe that because I see it so much, and I see it improve when we can get control of their POTS. And honestly, maybe another conversation. Why can't I get POTS cured in every patient? I have a lot of drugs I
That's my
can
entire
use,
point. It's like
and I
because
can't.
it's never in isolation. I guess that's what I'm.
Yeah,
That's it's a much easier way of saying what I've
yeah,
been rambling about, which is it's never isolated in my opinion,
right.
and I think that you would agree.
Yeah,
It's
no, I
you
totally
never
agree.
you never just have POTS and then you're otherwise
Right,
completely healthy.
right.
Never. And it could be something is evolving that you don't yet see. It could be they already have another diagnosis and this is now just an added component to it. But it's never in isolation. Never.
No, and it's not easy to treat. I mean, I often
No.
say I'll have a patient with vector-borne infection,
Mm-hmm.
tick-borne infection, and they say, "Come on, when are we going to get started treating this?" And what I will discuss is, well, I don't want to treat it until I have your POTS and your SIBO and your leaky gut and your mast cell activation under control, because that will make it otherwise it'll be very difficult for you to tolerate the treatment and for me to manage it. And those are the low-hanging fruit to fix first. So that sounds really cool, like I'm really smart. But I can't fix those things all the time. I mean, it still surprises me after all these years that I can't easily fix every patient with POTS, my definition of POTS, or every patient who has leaky gut, even though I think I understand it pretty well and I have lots of tools at our disposal. And I think you're right. It's because somewhere in there I'm still missing
Yeah.
something. And maybe as I
that's what
talk to you, this occurs to me, maybe I'm totally wrong and I shouldn't be going after the low-hanging fruit. I should go after the roots, which is the
Yeah, but
Lyme
you can
and the
always find
infections.
right. So in those patients, obviously, you know the roots.
Yeah, right.
You know the
Otherwise you
roots,
can't find them.
but not you can't always find the roots
Right.
sometimes, and so
Right.
you have to focus on symptomatic care, right? So which is the POTS, right? Because right now their concern is the fact that their heart is racing.
Right.
So you obviously the beta blockers, I know we've done a POTS episode where we sort of talked about our treatment options, but sometimes it is really the low hanging fruit because it's what's their most prominent concern, at least today, that it doesn't feel good when your heart is
Well,
racing.
it's what's immediately disabling.
Right. Right.
You know?
Because it doesn't, have you ever had your heart race? It doesn't feel
Yes,
good.
it's a horrible feeling.
I know.
Or
It's
having
uncomfortable.
palpitations like
Yeah.
PVCs.
Yeah.
It's horrible.
It is horrible.
All of a sudden you feel like,
Right. Right, absolutely.
yeah.
And you feel like your body's not getting enough blood because the heart can't fill appropriately. And anyway, I always make sure that patients at least have a cardiac workup. You want to make sure there isn't a malignant arrhythmia, that kind of thing. So you sort of cover your bases. But in general, it's usually just that the POTS is one thing it was one part of the elephant.
Right.
So I agree with you about POTS, and I think that the autonomic nervous system we should discuss that at probably in a whole episode because that's a very complicated system of ours, but that, as you said, keeps us alive.
So, again, going back to the three
The subtypes,
flavors of POTS.
the three flavors. Do
know,
you regularly test norepinephrine levels? I'm just curious.
No, I used to, but I've found it so unproductive.
Yeah.
I used to think I could find a pheochromocytoma. I've yet to find one. Or, the whole thing with norepi, I haven't seen it. But what I was going to say is, if you as physician just follow the rules, the three kinds, you're also not going to know how to treat the patient.
Right.
All right. So as an example, and maybe we covered this before, but I think it's worth covering again a little bit. When I first meet a patient and I do orthostatics in the office, and I don't need to do it for 10 minutes, even though I make them do it for 10 minutes. Usually after 30 seconds, frankly.
Mm-hmm.
The first question in my mind in terms of what to do is this postural orthostatic tachycardia for autonomic neuropathic reasons or for volume reasons?
Mm-hmm.
And frankly, there's no way to know.
No.
There is no way to know. And I sit there, I tell patients some of this, but they don't hear it all because it's in here. What should I do? Should I do the volume approach first, or should I do the beta blocker first to slow their heart rate down? And it's not an easy question to answer because there's risk. When you are volume depleted and you stand, the body, after 1 million years of evolution, has a reflex. And that reflex is to beat fast, to make up for it. And if I stand now, that's what's going to happen. My heart rate will go up until I equilibrate. If I slow that rate down, I may very significantly harm that patient.
Right.
Because now they can't even mount their compensatory response. Conversely, if I make the wrong decision and increase their volume, that rapid heart rate may not be able to keep up with this increased volume, and I could put them into heart failure. So it's a very tricky decision, and I don't have a formula to do it. I end up making a risk-benefit decision and a probability decision.
Right.
So in most patients, even though I know the references you're referring to about volume, in most ME/CFS patients, there is another literature that says they're all volume depleted to some degree. And I think in life, even without illness, we're all volume depleted. I guarantee most people you know and I know don't drink a minimum of 2 liters a day and take enough electrolytes because they're all thinking, oh, I shouldn't have salt, it'll kill me, et cetera.
Right.
So I generally will go for the volume issue first because it's probably less risky. And then it's drink.
Well,
drink
if you have healthy functioning kidneys, there's very low risk to just volume
and most
repletion.
of our patients have good kidneys.
Right, so the kidneys will. No, exactly. Thank God, because the kidneys will, as you know, just excrete the free water.
I'll go the usual conservative route: more fluids and more electrolytes. Not more salt alone, but more electrolytes. My preference being electrolytes without sugar and all the other garbage.
Right.
And then the next question is, do I use a pharmacologic agent to help increase their volume, or do I go for the beta blocker? And I use the lean test a lot to help me, but that lean test is useless unless the patient gives me their symptoms the entire time. And I just can't emphasize that enough to people listening.
Right. No, that's a really important point. Sometimes I don't even care about the numbers. I care about the symptoms.
Right, exactly.
Because it's the symptoms that I want to treat, right? Not necessarily the numbers. And while we can argue that it's the numbers that cause the symptoms, sometimes the symptom itself gives me a different idea to treat.
Yes.
And that's what's concerning to the patient is the symptom. And so I agree with you. It's the symptoms that are way more important. So I ask patients to just list. Sometimes I ask them to send it to me before the appointment just so I don't waste time on the appointment. So I just ask them to list, the symptoms that they're having. And I categorize them, which I think are related to their dysautonomia. And those I focus in on, and how can I get these better? And sometimes it's not about the midodrine and the fludrocortisone or the beta blocker. Sometimes it's something else.
Right.
So I agree with you. The symptoms are the most important thing. And I think that's just patient care though, right? That's what we're treating. We're treating symptoms.
Right. But yes, that's correct. I guess I want to emphasize again that, and this is more for physicians to understand and patients to understand, when you visit a physician, you're going to miss the diagnosis here. And I'll just, again, use the term POTS. If you just have your pressure checked in a seated position and maybe stand for 10 seconds, which is usually the routine way it's done, and nobody asks you how you feel.
Yeah.
Okay.
That's true.
So I just want to emphasize that, and I think we said this in our POTS episode. Everybody should just do their own lean test before they go to their doctor and bring it into your primary care doctor, especially if you're not already hooked into people like us and you're, kind of into the ME/CFS care world, because that may move that doctor, get that person to get to the heart of the issue more rapidly, more quickly.
You think?
I'd like to think.
I feel like any kind of measurement that's not done by the doctor themselves, they just don't validate. Unless they're, of course, doctors who are in our space, but...
Yeah, I think that may be changing. I don't know. I hope.
I hope so. That would be nice for patients if it were. But I agree. I think to bring any kind of information can only, add to convincing a doctor that something is amiss and that it needs some care and some acknowledgement and some treatment options for sure.
So let me ask you a question as a neurologist.
Okay.
So I would usually, as I just said, either start with, in a typical patient, typical being they present their POTS is their heart rate spikes and their blood pressure is either okay or maybe a little low, all right? I'll either start with volume and or beta blocker. One of the people in our listserv and masterminds, who's a neurologist, at some conversation earlier in this year, said, well, his initial intervention is always with guanfacine to treat hyperadrenergic POTS, even if their blood pressure isn't high. And I read this and I thought, holy shit, this is really an interesting idea.
No, I
really interesting.
I agree with that. I've used clonidine, not as much guanfacine, though I've changed actually.
I've changed because of the same
to
patient,
guanfacine, but I find that to be a lot more effective. But as long as does the blood pressure obviously, it can't be low. It has to be able to tolerate a small dose of
Right.
either guanfacine or clonidine.
But the change for me was I would never have considered that for the majority of patients who typically will have a blood pressure of 110/70, which is normal in quotes, right? Quotes, because you have symptoms. It's not normal, but in quotes,
Right.
it's normal. I would never think initially, oh, I'm just going to start them on guanfacine. But as I think about it, it makes so much sense that this is just another presentation of hyperadrenergic POTS, and maybe they don't have quite enough volume to mount the hyperadrenergic blood pressure they
No,
need.
exactly.
But
That's exactly
quieting
right.
down the sympathetic output with clonidine or guanfacine may be a way more effective way
Right,
of
but you have to
starting.
use low dosages, because one of the problems of the lower blood pressure, and obviously adding guanfacine or clonidine lowers it further, though these small doses don't seem to really have that effect, to be honest with you, but they could, is that you need blood pressure for perfusion.
Yeah, sure.
Right.
Sure.
So this is
Might make it worse.
well, this is where art over science comes
Yeah.
in, right? And this is why, again, going back to you need doctors who are treating patients to be at meetings, because we need to talk about this, right? We are on a daily basis. I balance patients' medications and responses. This is what we do: dosages and responses, right? Because we sort of see what's going on, and we obviously want to keep them safe, but we want to improve their symptoms. So you have to, think about, blood pressure is important for perfusion, and so you don't want to drop it too low, though. A lot of the medications that we use will drop it lower, but we want to keep it as high as possible. We don't want it to overshoot and go too high, but we need blood pressure for perfusion. So you have to sort of balance the dosing of guanfacine or clonidine so that you can accomplish that.
So what are you calling low dose?
Like 0.1, per day of clonidine.
Okay, that's the pill size.
Yeah.
Right. So I actually start even lower.
Oh.
So
Wow.
I'll start with half a clonidine pill or half a guanfacine to start for the reasons you're giving. And it's the same argument with if you default or go to a beta blocker. And I see this problem all the time. The patient comes in and says, "Oh, I tried propranolol. The doctor gave it to me 20 milligrams 3 times a day, and I almost died." Well, yeah, that's a little bit too much.
That's
If
too
all you
much.
want to do is slow the heart rate, I'll start with 5 milligrams.
I do too. With propranolol, I do too, largely because I worry about, a lot of these patients have HOP, right? So they have because of their mast cells,
Right.
which of course was never acknowledged way back when they were diagnosed with their asthma and their eczema and their allergies and such. And so I worry about their lungs and their breathing, with beta blockers.
I don't worry about that.
You don't? Okay.
I've never seen that be a problem. I know that
you don't
beta
have
blockers.
patients report they feel like there's more difficulty in breathing sometimes?
No.
Okay.
And I know patients tell me all the time, well, it says if you have mast cell, you shouldn't take beta blockers. I have not seen it be a problem. But
I think in general mast
it's
cell, I don't
because I
worry
use
about
these tiny doses.
Yeah, probably.
And you can slow the heart rate down with 5 milligrams twice a day or 10 milligrams max twice a day.
Yeah, I always start at 5 for sure.
Yeah,
I
always
tell
do.
them to cut them in half.
And
it's also propranolol is fatiguing. So a lot of our patients already have
well, that's
fatigue.
actually the biggest problem.
Yeah, so I try not to go and tell them to take. I started at night, of course, but
getting back to the
sorry.
No. I still want to talk
beta
about the
blocker. I love the beta blocker conversation though, just because I'm not a huge fan of the beta blockers, but I'm shocked at how many people are. And then I sort of see that other people are using different types of beta blocker beyond the propranolol. We'll get back to the other medication in a second. But the only reason why I've been sort of sticking to this conversation is because I'm just so curious about your experience with the beta blockers and the fact that you use propranolol versus some of, as other people use nadolol.
Right. So I start with propranolol, partly because I can dose it easily at a very low dose.
Right.
There's more dosing flexibility. It helps that it's been around 50 years and well understood. And then if I actually get to and this is something Andy Maxwell talks about also, get to a dose that works, I'll switch them to nadolol so I get a longer, because nadolol is basically long-acting propranolol. I will try the others. I don't use it very often because to me there's not much difference, but I will try atenolol because theoretically it doesn't cross the blood-brain barrier as much and therefore less fatigue. But truthfully, propranolol is always where I start.
Okay.
And I would add that while I usually choose the beta blocker to slow the heart rate down, you and I know well that beta blockers help with the sympathetic nervous system output and hyperadrenergic POTS.
Yes.
And so I end up with patients who are on beta blockers and guanfacine because I can't get the kind of control we need.
Right. Right. No, it's a recipe that needs to sort of be tweaked often,
Totally.
for sure.
Constantly
And it
needing
changes,
titration.
and I mean, sometimes I find the perfect dosing for a patient and they feel great. And then 6 months later, they don't feel great. So
Right.
then I have to
Right.
sort of tweak it again. But anyway, so back to you.
Well, no,
I
I
sort of
just wanted to
interrupted you.
emphasize that, number one, how interesting I found this neurologist's comment and how it really got me thinking.
Yeah.
And it makes so much sense because at the end of the day, I do think, as I've thought about it from this comment, that almost all of POTS is a disorder of the sympathetic nervous system and a fight or flight mechanism. And some
Yes.
patients present with a high blood pressure and some present with a low blood pressure. They all present with a rise in the heart rate and they all present feeling like shit when they stand up.
Right.
And I haven't had the guts yet to use guanfacine as my first drug just because.
Why?
Because I keep looking at that blood pressure, which is on the low side, and thinking,
I know, but you know that guanfacine is used for ADHD and tic disorders. So, like, I've used it in 6-year-olds, and they tolerate it really well.
Yeah, but I never used it. When I was a primary an internist in New York, I never used guanfacine. I just wasn't in my recipe book.
I think these drugs can be very, very useful.
Yeah,
for
no, I
patients.
use it a lot.
And I think, honestly, just, POTS and autonomic problems in general, I think, the more I think about all the symptoms of ME/CFS patients and chronic illness patients, like, I really think that you can find at least some relation to the autonomic dysfunction. I mean, even the sleep disorders that they have, frankly. I just think that there's, and, the whole, again, another topic, and I know that we're running out of time, but CCI and CMS, the cervical medullary syndrome, I think about the compression of the brainstem with all those nuclei that are involved in, autonomic control. Like, I think there's just, I don't know all the answers, but I think that the answers are there, and we need to just sort of look deeper into the autonomic function.
Yeah.
And I think there's going to be a day when we're beyond POTS. I feel like, all of this is, POTS is one of the septet diagnoses, again, because of lack of better clarity, maybe. But I think that this is so much beyond what POTS is narrowly defined
No, I agree.
as.
I agree.
Yeah.
And I think for our listeners, the takeaway to me, and the reason I got so interested in this subscriber's comment is we can't, as physicians and patients, we cannot let ourselves get imprisoned, to use the word from before, in definitions and in what makes it how you meet a diagnosis. You have to go over 30 beats for POTS when you stand up for 10 minutes. You'll miss so much, and you'll do such a profound disservice to patients. And as a physician, it's almost, this is probably too strong a statement, it's almost intellectually bankrupt to think that way in these patients. They're too complicated, there's too much going on at the same time, too much interaction, and you have to kind of...
Yeah, you're absolutely right. I mean, what you just said to me is so profound because it actually sort of triggered me. One of my biggest early complaints about medicine, and one of the reasons why I sort of went out on my own and sort of left that whole institutional academic kind of environment, was because I hated being told what to do by an algorithm or by a protocol or by a definition that needs to meet specific criteria, because I felt like I wasn't, doctors are smart, we're creative people. I felt like I wasn't being allowed to use my brain to treat patients. And that really bothered me because none of these patients fit into a box. And so I felt like to be able to be creative, to sort of think like, I don't care what the definition is. I care how I'm applying this diagnosis to you.
To this individual
patient. And by the way, when I think about all of the other more well-accepted diagnoses, especially in neurology, they're all different amongst patient to patient. Take MS, for example, which, we bring up a lot because people are talking about that as a post-viral illness now. Even though we have criteria of how to meet MS, like the radiographic evidence of MS is different all the time, and what parts of the nervous system are involved are different. Certain neurodegenerative disorders present differently. So nothing fits into a nice definition. I shouldn't say nothing, but most things, you fit into the patient's presentation based on a certain very strict number of criteria that have been given to you as guidelines, as an algorithm. about how to diagnose and then therefore how to treat.
Right.
And so like early on I would say that this doesn't make any sense to me because it's this patient is not fitting into this particular box of this algorithm, and so therefore I want to try to apply a different kind of box to them and therefore a different kind of treatment. But of course you're not allowed to, because then that's veering from the standard of care of medicine, and gosh forbid something went wrong, then I would be liable for not practicing standard of care.
And this
Does that make sense?
it
like
makes total sense.
Okay.
And it's the fallacy and the danger and the disservice to a vast population of patients, all of whom were addressed in that NIH meeting, just to tie it into the previous episode, when most physicians and virtually all employed physicians and virtually all residents in training are compelled, literally compelled, to think only in terms of evidence-based medicine and guideline-driven medicine.
Correct.
Which means you can't think outside the box. You're not even allowed to think about a box, let alone look at a box, let alone peek outside it.
Right, exactly. No, that's exactly right. It's so frustrating, right? 'Cause there's so many idiopathic diagnoses. We don't know why it happens.
Right.
Well, that's because we don't know why it happens.
Right.
So why give me a box to put
How do you
in?
have a guideline on something you don't know yet?
Right, or you take any neurodegenerative disorder, there's all these subtypes and variants. I mean, POTS is, and we were talking about the subtypes, speaking of subtypes, there's all these variants of a particular diagnosis that's accepted, or subtypes of a diagnosis that's accepted. Well, why are there all these variants? Why? Because we don't really know enough
and that's
yet.
why so many of our unfortunate patients end up being told you're neurotic, or you're anxious, or you need to get exercise because you're deconditioned, or you're just fucking crazy.
Right.
Excuse me, I'm sorry. I just get so
Don't be
upset
sorry.
about it.
It is frustrating.
And it's partly this whole doctor syndrome of clinical guidelines and evidence-based medicine. Follow the rules, and you only have 15 minutes to do it. So get out of here.
That's exactly right. Yeah.
So.
All right, we're going to end on that.
Yeah,
we're going to end on your cursing.
My New York genes come out. All right. Well, thank you very much. I don't know if I answered your message, but I tried.
We appreciate that message, though, because
yes, very much.
Yeah, and we like to address them. So, yeah, more messages, more comments, and we'll see you next time.
Okay. Thank you.
Bye.